Hydration of the drug electrode according to the instructions. Make sure you do that. And then placement of the electrode. Active over the treatment site. Make sure you do that. Dispersive at least 4 to 6 inches away. The video might note 3 to 4 inches away, but still about the same. On a major muscle. Do not press on either electrode. All right, so as we're using those electrodes, don't press on them, only on the outer parts around it. If you press on the inner part, you can produce an electrical burn, so you don't want to do that. Or you can push some of the medication out, because you're going to cause the medication to squeeze out if you do that. Or the current density can increase, so of course it's going to feel like it's more E-stem actively coming through. All right, may also cause leakage from the active electrode. So whatever you do, don't press on the, especially the center part of the electrode. At the bottom it says, do not put dispersive electrode under the body part, secondary to pressure. So any activity that's coming through electrodes can still cause problems if you have weight on it. So make sure you don't do that. All right, next page. So as the dispersion part, don't have the body part resting on the dispersion. Have it somewhere where it's not resting on the dispersion. Because even though you're not actually feeling it from the dispersion, the electricity is still going through that dispersion. And having it closer to the skin could actually cause more electricity to come through. And then you might get some sort of tingling that you don't want to get.
Meditation?
Yes, more so that. All right, next page. Connecting lead clips to electrodes. Light charges repel, we talked about that already. And drive the medication in at the active electrode. Cathode, which would be the negative black to the negative ion. So that would be dexamethasone. Attached to positive, which would be the anode, red, to the positive ion, or lidocaine. Okay. Now, parameters. It says set the time for 20 minutes. Current increase slowly to 2 milliamps. And then it says 2 times 20 equals 40 milliamps. And then it says alternative is 4 milliamps times 10 equals 40 milliamps. All right, what does that mean? All right, the bottom line is this person needs to get, of the drug that's there, this person needs to get 40 milliamps worth of electricity, okay, to send in the proper amount of drug. If I have 40 of these bulbs, it would take me 1 minute to put it into the body, and then go back, and then there's another minute. So the goal is to get 40 of these balls for this medication into the body. That's the goal.
Right. Isn't it too much for treating? Is it like 15 minutes only?
Aha. I'm going there. Yes, ma'am.
Isn't it 1 ball is 40 minutes?
1 ball is 1 milliamp. 1 milliamp times 40 minutes is 40 minutes.
Mm-hmm.
Now, what if I was able to take these 40 balls, but I took 2 every minute?
20 minutes.
20 minutes. What if I took 4 of these balls every minute? It would take
10 minutes.
10 minutes. Now, why is it that, because the goal is to get all of this into the body. That's the goal. But why is it that I have to choose maybe 20 minutes or 15 minutes based upon the patient? Based upon the patient. Can they handle this much drug going into them all at once? Because the more drug goes into the person, the more the prickling might be to a level that they might not be able to handle.
Does it have to be all 40?
We got to get it all in there, either slowly or fast. Okay? So, 1 milliamp equals 40 minutes. 2 milliamps equals 20 minutes. 4 milliamps equals 10 minutes. Because the bottom line is they're still going to get what we call 40 milliamp minutes of electricity. 40 times 1 is 40. 20 times 2 is 40. 10 times 4 is 40. They're still getting all 40, but we have to find a way to get it into them. But if there's some irritation that's there, if there's some sort of impedance that's on the skin, if it's a certain kind of drug, maybe we might have to change from dexamethasone to something else that's still negative that works on anti-inflammatory. We got to do what we need to do so that we can get that time down. But the goal is to get all 40 in. But the more we can take at once, the less time it will take. All right, so that's the goal.
Can we have 2 sessions? Since, for example, we have a patient with high irritation, and we need to have 40 minutes, and it's not enough. What we should do? Can we just divide it in sessions?
You're going to do the best you can until you get there. Now, when you look at your physical agents book, there's something called a 24-hour patch that has the medication in, and it sends it in over a long period of time. But the patient doesn't necessarily have to be with you. All right, so you can just cut it on, and it can go in nice and slow into their body. That helps to decrease some of that irritation because now we have the energy going in much slower into the body. All right, so there's another way to do it. You can check it out in your physical agents book. Okay, just trying to give you insight as to how it's done. All right, so let's go on to number 3. Roman number 3, effect. Maximum effect after 2 hours. So for here, the dexamethasone ions can attach to the white blood cells. All right, so after the 2 hours, the dexamethasone ions can attach to the white blood cells. Continued effect after 4 to 6 hours. And that's when you're going to get that decrease of inflammation and or decrease of pain. And you want to document any changes in edema or tenderness or pain, etc. All right, so that drug goes into the body, and any liquid that's a part of that drug will stay behind. So usually it's a water-soluble base that has an ion in it. The ion goes into the body. The liquid that the drug is in will actually stay behind and will not go into the body. And you'll see it in the video, and we'll explain it. Contraindications. Now, you see, all right, there's a big difference between a contraindication and being misused. Big difference. All right, contraindications mean I can't and should not use it. All right. Misuse means I can do it, but I need to be careful as to how I do it. Yeah, it is. Yeah. But I'm saying misuse because I'm doing it, but I'm misusing it. And when I get there, I'll show you what I mean. Why we say misuse. All right. So demand type pacemaker. Remember, the iontophorosis is still E-stem. So keep that in mind. Known sensitivity or allergy to drugs administered. So that's why you need to know, make sure that the patient is mindful of, that their doctor is mindful of what this person may be allergic to, so you're not giving them something that they shouldn't have. Because they can end up with a rash at that area. All right. Chronic pain. It's not going to help for chronic pain. It's only really used for acute and subacute pain. And then broken skin. Definitely don't want to do that.
Only on subacute, not even acute.
Acute and subacute. All right, you can add one to that. Blood clots. Or thrombus. You don't want to do that. Now, misuse. Misuse. You're using it wrongly. All right, so I do ultrasound before or after, and I'm doing iontophoresis. There was no problem with me using it. The problem is what I did before or after because I got rid of the drug. So I'm misusing the drug. Hot, hydro, or hot pack. Don't do that. Yes, I can still do ionto, so it's not a contraindication. It's just that I want to be careful with all that stuff. It's just going to increase circulation. And then vigorous exercise. I don't want to do that either. All right? I don't want to do that.
Is that before or after? Just, yeah.
Even before, you want to be careful of vigorous exercise, because if that blood is flowing pretty good before you put it on, it's just like water that you pour down, let's say a stream. Even though you stop pouring, it's still flowing. If you put something on that area and the blood is still kind of flowing, it can push away.
Did you tell us about the pacemaker?
Pacemaker's just like E-stem, so just be mindful of where you're putting it. It's really more so contraindication if you're treating the trunk area.
So if I have something in the lower extremity, it's okay.
E-stem on the trunk is especially long. Well, iontophorosis is the same as E-stem. All right, let's stop and take 5 minutes. That's all I can afford.
Iontophoric drug delivery from water-soluble corticosteroids with help over 1 million applications each year. The research is used to treat such ailments as hepatitis, and arthritis.
You don't get Chris.
The phoresis system is also used for the administration of local skin anesthesia. This program will explain the iontophoric process, discuss patient selection, and demonstrate the setup and proper use of the phoresis tube drug delivery system. Although the process of iontophoresis might sound confusing, it's really quite simple. In principle, it's similar to the more common transdermal method of drug administration, utilizing a skin patch. Only the phoresis system employs a very mild DC electrical current to move the drug ions themselves, seamlessly transport them through the skin, directly to the treatment site, leaving the liquid behind. When a positive charge from the phoresis system is applied to positive drug ions, or when a negative charge is applied to negative ions, they are repelled and transported to the skin beneath the drug electrode placed on the treatment site. The theory was first conceived in the 18th century, but only recently has modern technology and intensive research brought this theoretical technique into practical application. The portable, lightweight phoresis system from Iomed represents the state-of-the-art in iontophoretic drug delivery system, and because it's non-invasive, the process offers many advantages over other methods of therapeutic drug delivery. And clinical risks involved with needle injections are gone, since bacteria and viruses cannot be transported by electrical current. The risk of infection is virtually eliminated. Finally, localized delivery of site-specific medications by the phoresis system results in a reduction in systemic drug distribution, thus reducing the associated side effects possible with both oral and injected medications. The Iomed phoresis system is designed to treat a variety of common conditions where the administration of the water-soluble corticosteroids is indicated. The phoresis system is also used for administering local anesthesia prior to certain minor surgical procedures, such as cannulation, injections, biopsies, laser removal of dermal tissue, and dermabrasions. Be sure to refer to your phoresis system instruction guide for important information on indications, contraindications, warnings, and precautions, as well as polarity and fill volumes for the recommended medications. The phoresis system is contraindicated for use on electrically sensitive patients and those with electrical support systems such as pacemakers, as well as on patients with known hypersensitivity to the administered drugs. Damaged or denuded skin, scar tissue, right and left temporal regions should be avoided as well. Once you've chosen the phoresis system for your patient, follow these simple steps for safe, easy, and effective treatment. The steps are: advise the patient, fill the drug electrode, prepare the site, apply the drug electrode, then a dispersive pad, set the time and the current to achieve proper treatment. To begin, verify that the patient is not allergic to drugs to be administered, and let the patient know that some minor tingling or prickling will be felt under the electrodes and that it's harmless. Advise the patient to report any undue burning or pain at once during the treatment. Then, fill the drug electrode with the proper amount of the recommended medications to fully hydrate the gel pad. Be sure to keep the electrode level while filling and massaging the pad to ensure proper hydration. While the pad hydrates, briskly rub both electrode sites with an alcohol light to remove oils and contaminants. This is very important. Thorough cleaning with the alcohol light will minimize or eliminate the possibility of skin burns and the minor skin irritation normally caused by iontophoresis. Before you apply the drug electrode, look at the gel pad. The gel pad should look clear. Only the end seams should appear white or opaque. Then apply the drug electrode at the treatment site and secure it by pressing the surrounding adhesive. Apply the dispersive pad 3 or 4 inches away from the drug electrode over a major muscle. Never tape, bind, or compress either electrode, as doing so may cause excess skin irritation or burns to the patient. Then, attach the lead clips and be sure they are oriented correctly. See your phoresis system instruction guide for important information on connecting the lead clips according to the polarity of the drug being delivered. Now, turn on the phoresis module and set the desired treatment time by turning the timer knob. Then, slowly rotate the current knob to gradually increase current. The maximum current level is 4 milliamps. It is important to understand the relationship between time and current. The phoresis system automatically multiplies the current by the elapsed time and displays the result as milliamp minutes. The goal is to achieve a total delivered dose of approximately 40 milliamp minutes with treatment, depending on the patient's comfort level. You may treat for 10 minutes at 4 milliamps, 15 minutes at 2.7 milliamps, or 20 minutes at 2 milliamps. See your phoresis system instruction guide for important information on setting the time and the current to achieve the recommended total delivered dose. Upon completion of the treatment, the phoresis module will automatically power down and beep, indicating that the treatment is complete. Turn off the phoresis module. Disconnect the clip leads and carefully remove and discard both electrodes. Note the condition of the skin at both electrode sites. Careful patient selection and proper technique minimize skin reactions to treatment with the phoresis system. But there are a few typical skin reactions that should be noted. There are several individual factors which affect skin reactions. Fair-skinned or electrically sensitive patients will usually exhibit a slight irritation. Since the DC current tends to have a drying effect on normal skin, decreased moisture usually causes a slight reddening or even creates what appears to be an allergic reaction. So you may wish to apply a small amount of moisturizing skin lotion to the sites. Also, darker skin patients tend to show less reaction than do fair-skinned patients. Remember, thorough skin cleaning prior to application is the single most important factor in reducing or eliminating skin irritation and the possibility of burns. If skin irritation should persist or become severe, discontinue further treatments. Also, always use a new electrode kit for each treatment. Never attempt to reuse either the drug electrode or dispersive pad. And never substitute non-iomed electrodes. Reusing electrodes or substituting non-iomed electrodes has been reported to cause poor drug delivery, increased skin irritation, and even burns. The phoresis system is designed to provide safe, effective drug delivery for years to come. The built-in microprocessor automatically controls voltage while displaying time, milliamperage, and the calculated milliamp minutes. Warning lights accompanied by audible beeps will alert you to special situations. A few typical alert messages include electrode reject, indicating a circuit disconnection, usually at one or both electrodes. Check the clip leads at both the drug electrode and the dispersive pad. A low battery condition may prevent the phoresis system from initiating or completing a treatment. Replace the battery and start again. Battery reversed indicates improper installation of the battery. Reinstall the battery and begin again. Resistance limit indicates that one or both of the electrodes are applied to skin sites having high resistance. Check to see that both electrodes are firmly in place and not over scar tissue or thick skin, such as the sole of the foot. At some point during the procedure, you may want to pause the treatment. Simply turn down the current knob to 0, and the unit will automatically pause. To resume treatment, turn the current knob back to where you left off, and the phoresis system will automatically continue. The phoresis system is adaptable to a variety of application sites, including fingers and thumbs, the wrist and elbow, the shoulder, the jaw for TMJ, the knees, and the heel for Achilles tendonitis. For other applications or questions, consult your authorized Iomed dealer or call Iomed customer service at 1-800-621-3347. The Phoreser 2 Iontophoretic Drug Delivery System from Iomed. The state-of-the-art in iontophoretic drug delivery systems. From Iomed Incorporated, today.
So let me give some clarity to what we're talking about. All right, let's go to pelvic traction.
I have a question, quick one.
Okay, so we're looking at pelvic traction. And with pelvic traction, we need to separate or we need to pull. So we need to pull muscle or we need to separate a joint because there's some sort of pain or compression or something in the area. We're going to give an explanation as to what we're going to do. Keep doing the explanation of what they're going to feel as they strong pull. So let them know.
What page are you reading?
7. Feel a firm pull. You also want to find out if they had a treatment before today, how was the last session? Because if the last session is very irritating, and of course we want to be mindful of either not doing it today or not doing as much today. Okay? And then you can give the patient a gown, and then we can get started with our check. Okay? Now, STRP. I would suggest that you do RP while the patient is standing. And then ST while the person is getting, well, no. You can probably do all of it while you're right there. So, unless the person is going to go prone, and then you can check it afterwards. But you can check the range. So the person is there, you don't have to give them a gown when you first start. You're sitting in the chair right now, I might do range of motion right now. Okay, so can you twist to your right or to your left? They still have clothes on if you want to go to this point. All right, and to your left. All right, now, I wouldn't do flexion and extension while they're sitting. I'm already sitting at 90 degrees. So don't ask them to do range of motion or rotation while they're sitting because they're already at 90 degrees. Then you might ask them to stand up. And then check side bending. And then flexion and extension. All right. With flexion and extension, you may want to sit and then have them stand with you sideways. Stand for a second. So as he's flexing, I might be here because he could hurt himself going too far, so I want to guard what he's doing. Okay? So we can do that. So I can check range of motion, and I can also check pain scale. Now, one thing we need to stop doing, and that is, you had a question?
No.
Yeah. Is checking pain scale with palpation. We want to stop doing that. Okay? Why? Because if I say, on a scale of 0 to 10, how's this? And she said, oh, it's not that bad. And then the next person comes behind me and says, on a scale of 0 to 10, how much is that? It's going to be more. So stop checking pain scale with palpation. I'm sorry. We want to check pain scale with movement and no movement. So just sitting there, how's the pain? When you twist, how is the pain? When you move, how's the pain? Not when I press, because everybody's different. Yes.
Active and passive.
Active. I won't necessarily passively move them myself.
Still the same.
Not their back. Yeah. All right. So you did the pain scale. Then of course you're gonna look at the skin. So at that point, if you want to put a gown on, you can put it on. So you don't necessarily have to put it on right then and there. You can put on the gown, then you can go ahead and look at their skin and check them. All right, now, some clinics may do it differently. All right? Some clinics may put the heat on and this big traction belt at the same time. Okay? I'm not going to say it's wrong, but I'm going to say that these belts are very thick. All right, very thick. So you just want to be mindful of the heat actually going through this to really get to the skin to treat the area. So I won't say that it's wrong, but I will say that it's very thick. I know that we contend with the fact that you don't get paid for heat. So we try to combine some things in order to save time since we don't get paid for that. But the bottom line is this is thick. And putting heat on with this may not be the best thing to do. All right?
To be
Huh?
the heat and then,
Versus heat
and then do separate.
and then traction. Right, right. So I'll just say it that way. Okay. So we're going to do the heat first. Make sure you check the skin afterwards, as it says there in number 6. And then you want to also be mindful of determining the pounds of traction. All right. Let's go to that page I showed you on 33. Yeah, 33. All right. So let's say that the person is that first column, acute strain, spasm, pain. The person would be in the supine position. We would use that intermittent 40 seconds on, 10 seconds off, 10 minutes up to 20 minutes treatment time. I'm going to increase by 5 minutes each session. I'll get to all of that a little bit later. But I'm going to get to the pounds. Half the body weight. All right, so half the body weight minus 20 pounds. And want to increase about 5 or even 10, sometimes, but 5 each session. So, your patient weighs 200 pounds. All right? Half the body weight is 100 pounds. Minus 20 pounds is 80 pounds. That's where I'm going to start today. Okay? Then it says increase by 5 each session. Each session. And we're dealing with an intermittent protocol. So intermittent protocols, we want to increase each session. Increase each session. All right, let's go back. Okay, so that's how you get the pounds of traction. Now, a split table versus a non-split table. All right, so if I have the portable unit, which is this unit right here. This unit right here. This is the portable unit. In many cases, I might be using the portable unit with a non-split table, like that brown table in the back. Okay? But for the most part, I have a table like this here. That is what we call a split table. Okay? And I can unhook the table, and then the person will be moved back and forth on this table. And I just need to make sure I lock it before they get up, because they can hurt themselves if I don't lock it back. Or I can have this table here, and it goes back and forth. Okay. Now, the difference between both of these tables is this table here locks with a hook. So I move the handle, out, slides back and forth. I put the handle back, it goes back and forth. This one here locks with tension. So if I unhook it, if I have it locked first, it goes like this here. If I unhook it, it becomes disengaged from, and then it slides back and forth. If I tighten it back, this basically goes back up like that, and friction keeps it in place. Okay, so that's a split and non-split table. Now, if I'm using a split table, I'm going to use the pounds that I just said. 100 pounds, for example, 50% of that is 100 pounds. I'm sorry, 200 pounds. 50% of that is 100 pounds minus 20 is 80 pounds. That's my start pound. If I'm using a non-split table, so if I have a portable unit, okay, and I hook it up to that table over there, there is no split. Tell me why you think that there's the purpose for the split. To separate, but to do what? Reduce friction. All right, so we use a non-split table to reduce the friction, or a split table to reduce the friction. A non-split table, we can't reduce the friction. Okay, so since we can't reduce the friction, we need to do something. Since we can't reduce the friction, so we want to add 25% to overcome the fact that we can't split a table. So, if we have a non-split table, the patient weighs 200 pounds. Half of that is 100 pounds. Minus 20 pounds is 80 pounds. All right. 25% of 80 is what?
20.
100 pounds. So I'm going to start with them with 100 pounds.
Wait.
When I'm using a non-split table.
Why?
Because I don't have the split to overcome the friction. So I need to give more pounds.
So you need the friction, not avoiding friction.
I need to give more pounds because I have more friction. Here I have less friction. The table slides back and forth. There I have more friction. So since I have more friction, I need to add more pounds to overcome the friction that table is giving me, because it won't allow the body to slide on that table. Okay. All right, we'll hit it some more. All right, now the split table. When the patient lays down supine on the split table, L4, L5 needs to correspond to the split. All right. L4, L5. So I know that the split is right here. All right, so I want to make sure that they lay L4, L5 at the split. Bottom part of the pelvis will be here. The upper part of the back will be here. When they pull, it's going to give a nice pull right here. This part will be on the bottom part of the table. This part will be on the top part of the table. The split, nice and easy, will go back and forth right here. Okay. There's a non-split, then there's nothing you can do about that. That's why you want to add more pounds to overcome the non-split that's there. All right. The pelvic belt. All right. This is the pelvic belt. All right. And the pelvic belt is going to go on, and we want the top ridge. Belts look differently, so I'm just giving you an overview. Some belts are different in some clinics. But the top ridge is going to go above the iliac crest. All right. So we'll put this on. I'll make sure that that top ridge above the iliac crest. Why? Because when the belt, when it pulls, when I tighten the strap, it's going to pull on and pull down on the crest to separate the body. All right, if I have it below the iliac crest, it's going to do that. It's going to just pull straight down. It needs to be above the crest so it can actually get a grip and hold on to the actual bone. All right. Now, I want the back straps. All right, so So these back straps right here, back straps are going to correspond to the ischial tuberosity. So I want these back straps to pull straight down the ischial tuberosity. And you see that there's two belts, or two buckles rather. I want to tighten both of them, and I'll have a top big belt on too. But out of these two, which one do you think should be the tightest?
The
Top one.
Which one?
Top one.
The top one. All right, so this is the one I want to be the tightest hole around those iliac crests. So the top pelvic belt should be the tightest. Now, I also have a thoracic belt. All right, thoracic belt. Now, I want the web portion. Okay, I want the web portion to pull on ribs 8, 9, and 10. I want this rounded, look like a meniscus almost. I want this part here, this web, is going to be on both sides. To be on ribs 8, 9, and 10. And 10. All right. Why? Because those are the ribs down the bottom, and then when you get that good pull, it's going to pull that way. So then where you're going to get counter traction. You get the pelvic belt pulling one way, thoracic belt pulling the other way. All right. Now, you offer. Question? Yes, go ahead.
Yes, because of the splitting table, you told us it's L5, L4, it's for the pelvic.
Right, so if I have the pelvic belt on right here, the split of the table is going to be right here.
About the thoracic is where?
Thoracic what now?
The thoracic traction.
Thoracic is going to be on the top part of the table. So this part of my body is going to be on the top part of the table. This part of my body is going to be on the bottom part of that table. The split in the table is going to be right here.
For both the pelvic and thoracic traction?
Well, it's only pelvic traction. It's not really thoracic traction. And this is just a thoracic belt.
Oh, okay.
Thoracic belt,
Gotcha.
pelvic belt. I'm going to lay on the table, and the split is going to occur between the two belts.
Okay, gotcha.
Yeah.
The pelvic
So
tract.
they have to have both down.
Yeah, otherwise, what do you think is going to happen? Let me tell you what's going to happen.
Yeah.
About 4 or 5,
Years ago.
maybe about 10 years ago,
Oh,
we had a little teeny weeny girl. Little teeny weeny, little. And she was on the table. And she eventually came off the table. Because, so, that's why you want to have it. Well, she had some problems later on, but we won't talk about that. Now, you want these straps. All right, you want this strap here
This seems like so much.
to go over the acromions.
Straps over acromions.
Because there's going to be a pull that's going to happen at the top, and there's going to be a pull that's going to happen at the bottom. Okay. Which belt of these two belts should be the tightest? Bottom belt. So bottom belt of the thoracic belt should be the tightest. Top belt of the pelvic belt should be the tightest. Okay. Now, in some cases, you may have to add a towel, a little cloth or something right in here as you're tightening. Reason being is you want to make sure that there's no puncturing of the xiphoid process. So you want to make sure that this top belt is below the xiphoid process, because you don't want it to poke into that xiphoid process. Yeah, below. All right, spreader bar. All right, so we put the person on a spreader bar. I'm going to hook up Randy in a second. All right. Now, we don't have to do a spreader bar, but if we do a spreader bar and we get the pull is going to come into ischial tuberosities. We can get a good pull at the back. We could just pull at the D-rings. The person is nice and small. We want to use a spreader bar just like we want to use with the cervical traction if we use the halter. If we don't use a spreader bar for cervical traction, the person can get that, because all the pull is going to be like this here. If the person has, if the person is really blessed on the side, okay, then if you don't have a spreader bar, that side strap of the pelvic belt could dig into the blessing on the side. So if we can get a nice spreader bar, we can get a good even pull on both sides. Okay. All right. So let's put Randy on, and then we'll go on.
You looking like, oh no. Silly. Stand up. Stand up. Get up. Kedrick, you should know this classroom by now. Stay hurting yourself.
All right. So.
I know. Swing the patient around.
All right. So we're gonna put the. Pause. You just gonna clip. Did it fall off? Oh. God bless you. Thank you. All right. So this is the top pelvic belt. I want that to be thick. In the bottom. All right. So that's on. And then here is the bottom thoracic. Now, make sure with these thoracic belts, you don't want to have this belt on right here where it's like a bustier. You want it to be on the side. So it shouldn't be, like that. Got that on tape, so now I know you understand.
The man's ear.
The man's ear, yeah. All right, again, so the bottom belt here
looks like so
tight.
Got a lot of cushion in the front, but they can't be squeezing.
So sometimes it's good to push the belts to the opposite side and then pull. Pull. You okay? Pull. Make sure the patient is in the center.
So, again, which one's the tightest?
The down.
These two.
On the bottom, the top, on the top.
These two right here. So bottom, top of the pelvic, bottom of the thoracic. Marco, can you pass me a stool there? All right, then we want the body to be in the center. All right, we want to pull straight through the navel. All right, and then we're going to take this arm and go right in here. All right, Randy, help me out now. Good. Good job, Randy. Good. And this arm. Good. Thank you, sir. Thank you. Good. All right, patient has back pain. Never ask the patient to raise their legs by themselves. So you're going to help them with their legs. Put that.
He's had that wound for a very long time.
Now, I want you to look up here. Tighten.
This is serious.
I know.
You had to go to the bathroom?